This is the 11th in a series of videos on glaucoma training. Module 11, Treatment. The learning objectives in this module are to understand why it is important to reduce intraocular pressure in glaucoma, to understand the various treatment options available, and to understand the challenges in treating glaucoma. All treatment for glaucoma is designed to reduce intraocular pressure to a level where the risk of further damage to the optic nerve is minimized. Even if you are not directly involved in administering treatment or prescribing medications, you have an important role in managing the long-term care of your patient. It is increasingly important that you are able to recognize when there are compliance issues, side effects, or a change in condition requiring referral back to the ophthalmologist. Since the loss of vision from glaucoma is irreversible, the key aim of any treatment is to prevent vision loss or to halt progression where damage has already occurred. From a medical perspective, the principal goal of all glaucoma treatment is to lower intraocular pressure in order to preserve visual function with minimal side effects for the lifetime of the patient. Lowering IOP is the most successful way to treat glaucoma. It reduces the risk of ocular hypertension progressing to chronic open-angle glaucoma. Lowering IOP also slows the rate of COAG progression and is effective in reducing the risk of progression in normal tension glaucoma. However, it should be noted that IOP lowering treatment will not benefit all glaucoma cases. Successfully reducing IOP to the optimum level is dependent on a number of factors. The degree of disc damage and/or field loss must be considered along with the estimated progression rate, if this is available. Age, life expectancy, and the presence of other risk factors, such as a thinner than average central corneal thickness, CCT, will also influence target IOP. These factors are taken into consideration in this diagram, depending on how early or advanced the damage is, how short or how long the life expectancy is, and how high or low when the damage occurred was the IOP. This allows you to set a higher or a lower target IOP for treatment. Treatment options. IOP is lowered by suppressing aqueous production and/or increasing aqueous outflow. The three main ways of achieving this are topical pharmacology, which is usually eye drops, laser treatment, and surgery. And a number of options are available in each category. Topical medication. Eye drops are widely used to lower IOP by either improving drainage and/or decreasing the amount of fluid the eye produces. Drugs to treat glaucoma are classified by their active ingredient. These include prostaglandin analogues, PGAs, beta blockers, carbonic anhydrase inhibitors, sympathomimetics, miotics. Combination drugs are available for patients who require more than one type of medication, and while the benefits are clear, each medication does have a number of potential side effects. When a topical medication, such as a prostaglandin analogue, is used to lower eye pressure, the target IOP can vary. It is decided based on risk factors. For higher risk patients, the target pressure is lower. Eye drops are usually well tolerated, but the cost may be prohibitive compared to a minimum wage in many sub-Saharan African countries, which is an important consideration when a patient is likely to use them every day for the rest of their life. It should be checked that there are no relevant comorbidities or potential drug interactions before offering pharmacological treatment. Any cognitive and physical impairments should also be taken into account when making decisions about management and treatment. Topical medication options. Prostaglandin analogues. Prostaglandin analogues treat open-angle glaucoma by increasing the uveoscleral outflow of intraocular fluid from the eye. The aqueous inflow is not affected. Taken as eye drops, they are available in a number of different preparations and often referred to by their trade names. Preservative-free options are suitable for people with allergies. Options include latanoprost, often called Zalatan, which is also available preservative-free as monopost. Travoprost, known as Travatan, Bimatoprost, Lumigan, in different strengths, and Tafloprost, which is only preservative-free. Adverse effects of prostaglandin analogues. Ocular adverse effects include gradual change in iris colour and the growth and darkening of eyelashes. Other side effects can include stinging, blurred vision, conjunctival hyperemia, itching, and burning. Occasionally, systemic side effects include the exacerbation of asthma, chest pain, and palpitations are possible. Depending on the individual, one brand of prostaglandin analogue may be more effective and produce fewer side effects than another. Beta blockers. Ocular beta blockers, beta adrenergic antagonists, work by decreasing production of the aqueous fluid to lower the IOP. They can be used alone or in combination with other prescribed topical glaucoma medication. Available in generic form as topical eye drops and relatively inexpensive, they are usually taken 1 or 2 times a day and have the potential to lower IOP by an average of 20 to 25%. Options. Well, the most commonly used options are timolol, 0.1, 0.25 and 0.5% as non-selective beta blockers, and betaxolol in 0.25 and 0.5%, which are beta-1 selective. Non-selective beta blockers block both beta-1, the cardio, and beta-2, the pulmonary adrenoceptors, and are the most effective at lowering IOP. However, they are associated with more side effects. Beta-1 antagonists are cardioselective, meaning they block only beta-1 receptors. While they have a better safety profile compared to the non-selective beta blockers, the IOP lowering is slightly less effective. Beta blockers can affect cardiac activity and cause adverse side effects in individuals with certain heart problems, lung problems, or other conditions. Systemic side effects, such as low blood pressure, reduced pulse rate, and fatigue are also possible. Beta blockers can also cause shortness of breath in people who have a history of asthma or other respiratory disorders. These side effects can be minimized through application technique to prevent the active ingredients from entering the systemic circulation. Ensuring your patient is applying the drops correctly is crucial to the long-term success of this method of treatment. Local side effects of beta blockers are usually minimal, but can include dry eye and redness. Carbonic anhydrase inhibitors. Inhibitors reduce aqueous production and lower IOP by an average of 15 to 20%. They are often used in combination with other anti-glaucoma medications and are available as eye drops or pills. There are two main topical preparations: brinzolamide, known as Azopt, and dorzolamide, Trusopt. Carbonic anhydrase inhibitors are usually taken 2 or 3 times a day and are generally well tolerated. Common ocular side effects include eyelid reactions and ocular burning and hyperemia. Sympathomimetics, also known as alpha agonists, these both reduce aqueous production and increase scleral outflow to a limited extent. The main options are brimonidine, 0.2%, and apraclonidine, 0.5 to 1%. Brimonidine has a purite preservative that breaks down into natural tear components. It may be more effective for people who have allergic reactions to preservatives in other eye drops, and is available in a generic form. Side effects can include burning or stinging upon installation of the eye drop, fatigue, headache, drowsiness, dry mouth, and dry nose. Miotics, most commonly pilocarpine, reduce the IOP by increasing the drainage of aqueous fluid through the trabecular meshwork due to pupil miosis. Pilocarpine is rarely used in the management of COAG, but is still used in the management of angle closure glaucoma. Many patients complain of dim vision at night due to the pupil miosis. Combinations. Topical combinations of 2 treatments in 1 eye drop are normally prescribed when adherence is an issue or multiple therapies are required. A combination of medications can help control aqueous production and outflow. Preparations are usually combined with timolol 0.5%. So Xalacon is latanoprost and timolol taken once a day. Duotrav is travoprost and timolol once a day. Ganfort, bimatoprost and timolol once a day. Cosopt, dorzolamide and timolol twice a day. Azarga, brinzolamide and timolol twice a day. Combigan, brimonidine and timolol twice a day. Or the option of Simbrinza, which is brinzolamide and brimonidine twice a day. Side effects are generally consistent with those for the individual medications. Topical treatment for ocular hypertension and chronic open-angle glaucoma. NICE has to balance effectiveness of treatment for glaucoma against cost to the English National Health Service. Previously, NICE recommended a generic prostaglandin analogue in the first instance to patients with ocular hypertension, where the pressure is 24 millimeters of mercury or more, and chronic open-angle glaucoma. If the patient cannot tolerate the treatment, an alternative therapeutic class of drops can be used, starting with a beta blocker and including combinations. As of January 2022, NICE now recommends laser before drops or surgery following research at Moorfields Eye Hospital. Selective laser trabeculoplasty has now become first-line treatment for open-angle glaucoma and ocular hypertension. There are good reasons for considering laser or surgery rather than drops in sub-Saharan Africa. Laser treatment was historically used when topical medication failed to bring down eye pressure. However, it is increasingly being used as a first-line treatment instead of medication. It is an attractive option for reducing intraocular pressure, as side effects are minimal, but the effectiveness can wear off over time. There is a need for more training of surgeons in the skills required to carry out the procedure in sub-Saharan Africa. Laser trabeculoplasty is the most common form of laser treatment for open-angle glaucoma and ocular hypertension. The laser is aimed at the trabecular meshwork to help enhance the outflow. It is a very quick procedure performed at an outpatient clinic with local anaesthetic and is considered risk-free. There are two main types of treatment: argon laser trabeculoplasty, ALT, and selective laser trabeculoplasty, SLT, although SLT is used much more commonly in modern glaucoma practice. Patient outcomes. Laser trabeculoplasty is a relatively non-invasive treatment which can lower IOP by up to 30% and is successful in about 70% of patients. It is important to note that the effect of laser trabeculoplasty is diminished over time, and only 50% of patients retain IOP control after 5 years. However, the procedure is repeatable and has few side effects. NICE now recommends laser trabeculoplasty for patients with OHT, suspected COAG, or COAG as an option. It is also recommended as an alternative for patients who prefer not to have surgery. In some hospitals, specialist glaucoma optometrists are involved in the delivery of SLT. Cyclodiode therapy, transscleral cyclophotocoagulation, is laser treatment performed under local or general anaesthetic in an operating theatre. The laser is fired at the ciliary body to reduce fluid production, an inflow procedure. This surgery carries a slightly higher risk than trabeculoplasty, with the potential for inflammation or the possibility of lowering outflow too much. Traditionally used in severe cases of glaucoma, advances mean that it has become a slightly less destructive procedure, and it is increasingly used earlier on to halt the progression of glaucoma. Other laser procedures. Endolaser cyclophotocoagulation, ECP, is a procedure to lower IOP and reduces the need for glaucoma medications. It is often combined with phacoemulsification in cases of cataract surgery and medically controlled glaucoma. Approaches to glaucoma surgery. Surgery is usually considered when glaucoma is at a moderate or advanced stage if topical medication and laser therapy are not effective. Surgery has the dual aims of significantly lowering IOP and substantially slowing the progression of glaucoma. The common options are minimally invasive glaucoma surgery, MIGS, trabeculectomy, non-penetrating glaucoma surgery, and glaucoma drainage devices, or tube surgery. Minimally invasive surgery can be used in mild to moderate forms of glaucoma and is often part of a mixed procedure combined with cataract surgery. Trabeculectomy is an invasive surgery which lowers IOP inside the eye in patients with advanced glaucoma. It's the most common glaucoma surgery in the UK and has been performed for over 50 years. The outcome of the procedure is a small hole in the sclera covered by a thin trapdoor. The aqueous humour drains through the trapdoor to a small reservoir called a bleb. just under the eye surface, hidden by the eyelid. The drainage of the aqueous results in a lowering of the IOP. Following successful trabeculectomy, you would expect to see a bleb with minimal vascularization and an elevated, well-defined anatomy. It will drain well and pressure will be within the target range. Concerns include redness, patient experiencing discomfort, or increased eye pressure. Long term, some trabeculectomies will begin to fail as the bleb may become scarred and the IOP may rise. Resurrection strategies include bleb needling or revision to break down scar tissue. Non-penetrating surgical options. The most common non-penetrating surgeries are deep sclerectomy, viscocanalostomy, and canaloplasty. Following non-invasive surgery, about 2/3 of patients need a further procedure, a goniopuncture, a procedure performed with a YAG laser, to further assist the lowering of IOP and minimise the chance of further invasive surgery. Drainage devices, tube surgery. Glaucoma drainage devices, commonly known as tubes, are used in advanced cases when other procedures have not been successful or to treat certain types of glaucoma, such as neovascular and phagomorphic glaucoma, where scarring is intense. The tube, a type of hardware inserted in the eye, is more resistant to scarring. There are two main types, the Ahmed valve and the Behrvelt tube shunt, which does not have a valve. Trabeculectomy would usually be the first-line procedure for penetrating glaucoma surgery. For secondary surgery, where earlier treatments have failed, the tube procedure is better as it scars less in the long term. However, complications that can arise include double vision and possible damage if the tube erodes through eye tissues. Following tube surgery, the tube should be fully functioning after 6 to 8 weeks. There will be a large bleb, but it is situated posteriorly and largely encapsulated, so it can be difficult to see. If the eye pressure is still too high, refer back to the hospital eye service for treatment to make the tube work better. Occasionally drops are needed to work in conjunction with the tube to bring the eye pressure down. So in summary, treatment for glaucoma, if administered correctly, can preserve the patient's eyesight for the duration of their life. However, it is a situation that requires monitoring to ensure the treatment plan remains effective. Topical treatments are widely used and highly effective, but many patients find them difficult to comply with. Laser options offer a number of benefits, but may be temporary, while surgery is typically only used in moderate to severe cases. Make sure that you have achieved the learning outcomes for this module. To understand why it's important to reduce IOP in glaucoma, to understand the various treatment options available, and to understand the challenges in treating glaucoma. Make sure to have any of your questions answered.